preparing something very, very fun and really awesome to all of us. So please scan this QR code or get the link that you are going to type on the Q&A chat box, so you're going to be able to vote in our questions. Next Thursday on 15th of October, we are going to have our nightmare cases. It's Thursday or Tuesday? I'm on vacation, guys. Sorry. Yes, it's going to be Tuesday. No, today is Tuesday. It's going to be Thursday. Sorry for that. We are going to have the first one of a new webinar series. We are going to have nightmare cases, tough cases that some team all around the world faced before, and they are going to tell us how it was and how they solved the issue and how was the outcome. And this is going to lead us to a lot of discussion, and everybody can learn from that. So I hope you can join us next Thursday. The first nightmare case is going to be presented by the team of Aswan in Egypt. We are going to have Dr. Anderson every Friday. This Friday, he changed a little bit the schedule. He's going to talk about single ventricles in general, and we are going to type the link on the chat box as well, so you can join us next Friday. And on Monday, Dr. Silverman is going to talk to us in a very nice session, because he makes the correlations between morphology and echocardiography images. So he's going to talk about ventricular septal defect next Monday. Please join us on this session as well. And now Gil is going to start and to talk to us how this amazing session is going to be. Thanks everybody for joining us today.
Thanks, Grace, and thanks, Sasha, and thank you all for tuning in at this point. I keep getting spam calls of who to vote for, so you'll apologize me. They're coming left and right here in the United States. I do want to thank the panelists who have taken some time out from their busy day to have an informal session today. Well, I guess it'll be a combination of formal and informal, trying to mimic what we do at bedside rounds. I thought for this particular session that we would talk about developing a workable environment and systematic approach to looking at postoperative congenital heart disease patients. We're going to break it into three particular areas. I'm going to see if I can get my slides to actually work. Is the volume okay? Is the all that sort of stuff okay?
Perfect.
Okay, good, thanks. Okay, let me come down here. So first off, I want to thank the members of the panel who really come from all over the world, as you can see. A few people are going to be joining us a little bit late. We're going to talk about the care team and conflict that may occur in the intensive care unit. What happens when babies right out of surgery arrive to the intensive care unit, and how to think a little bit about a handoff structure, the first postoperative night, and then the handoff over the next few days. And we'll stop a few times along the way. As you can see, these people come from many, many places. And I really, again, want to thank them. Duncan McRae has brought his expertise from London to Doha, and Grace Van Leeuwen from Sao Paulo. Also over on the east there, we've got Sasha Agati, who's the co-founder of the Academy with me, in Taormina, which I still believe is the most beautiful city in the world. And Peter Oleveld from Leiden up there at the top. And then over on the western side of the United States is Dave Axelrod from University of California, San Francisco. Paul Kekia started at Loma Linda. He spent a little time in Chicago, and then he's ended up there in Houston. At the top, Jai Jai from Toronto Sick Kids, Stephanie Fuller from Philadelphia. I've worked a lot on the East Coast, Boston, New York, Philly, Miami, and now I'm here in Washington, DC. And then I also do want to add to thank Brian Siegel. Brian is a recently double boarded fellow in cardiology and critical care medicine at DC Children's or Children's National Hospital and is now working in Boston. And I asked Brian specifically to come on as someone who's recently been training and can give you more, I think, practical points about what is necessary, what he wish he learned in fellowship, how he's applying that into his attending years. And I have to say, Brian knew nothing about this. I just called him about 36 hours ago. And all of these people, none of us have prepared for any of this. So we're really very, very excited to put this together. We have people from 101 countries that have registered so far, truly remarkable. A number of countries in Africa. We have many people from countries that, this is just an example, I couldn't even get all the names on here. People that are in the middle of the night in their countries, in India and in Japan. And I'm really, really thankful for the many, many people who've registered, and hopefully we can have a good dialogue as we move forward. So what I'm going to talk is the systematic approach to neonates and infants, specifically after congenital cardiac surgery, and how we can turn rapidly babies, neonates defined as less than 30 days, and infants probably less than 6 months, although most of them are 2, 3, 4 months of age. We all know babies are not small adults. We know that babies are not even small children, and we know that neonates, physiologically at least, and we'll talk about this a little bit, as it relates to postoperative care, are not even small babies. The neonate with congenital heart disease poses completely different challenges compared to infants and older children. And just for a few examples, the operations that our babies get, that our neonates get, are different. They tend to be more complex lesions. So they're long operations and small structures. In some units around the United States, half of these neonates could have a univentricular heart. Because of that, many or most are on prostaglandin E1. It's very common, not only from the acute changes of the transitional circulation to the left and right ventricle, but from the operation itself, can greatly change the loading conditions on the immature myocardium. And many of them have much more invasive monitoring due to the complexity of the operations. I think an area that is ripe for research is the families of babies with neonatal congenital heart disease. One thing that's very different is they've never been home. They've never been home with their baby for the most part, setting up a support structure, a pediatrician, getting things ready for looking after the other children. And it's been measured on multiple times that they're at much higher stress than families that come in more electively for surgery. It's also been shown, Sarah Hohn at Children's in Philadelphia and others now have shown that they're less likely to participate in clinical research. And then, of course, the neonate is different. They have a tendency to have more capillary leak following cardiopulmonary bypass. I mentioned before the loading conditions are different. The heart, kidneys, brain, and lungs are very immature compared to what they would be even 2 to 3 months later. Nutritional reserve is a potential problem. They're immunocompromised. They may be vulnerable to nosocomial infection. You put all this together, and they have longer length of stay than most of our admissions. The average in most units is about a month, as you can see down in the bottom right, but there's many, many outliers. And I think work on decreasing the number of outliers, the patients that need chronic cardiac critical care, I think will greatly improve the results, not only for the babies, but decrease cost, et cetera. And all of this is related, of course. So you've got this more invasive monitoring, a longer length of stay, more potential nosocomial infections. And although in many units, neonates account for only about 25% of the admissions, they account for 50% or more of the bed days in units that are doing a lot of neonatal surgery. The longer length of stay also leads to higher stress, which is one of the strongest components of long-term neurodevelopmental problems. Longer length of stay and higher family stress. What's your team like? Well, you have to have a knowledge base of you can see all of them listed here. I'm not going to go all the way through them, but you've got to understand the complexity of the congenital heart disease, how it relates to the transitional circulation, all the different surgical repairs, what bypass does, then multi-organ system failure, how the ventilator interacts or spontaneous breathing interacts with the cardiac system, et cetera. And in cardiac and pediatric congenital cardiac intensive care, there are a number of technical skills, as you can see here, that range from access to cardioversion to imaging to exploring the chest. And it's important when we think about what our units are like, there is nobody who can possess all of these characteristics. And we have to put together a team that has complementary skills and knowledge and must work together. I'm going to talk just a little bit about philosophy. We're going to switch to an audience poll to get an idea of what we have. There's a couple ways to get to the poll. The first is to scan this QR code. And then if you have another device where you can log on, either your iPad or your phone or another browser screen, please type in ahaslides.com, post-op plan, all in caps. It's case sensitive. And I'm going to do a new share here, see if I can get onto my, no, it doesn't look like it. Give me just 1 second, guys. I want to stop this. Okay, and I see we have a number of people here. This is always the problem when I use multiple screens, and I really do apologize for that. I got to make this down there, escape out of this. I'm having trouble for some reason with sharing my screen. And it's a shame because the poll is really quite fun. Do you see anything or have any suggestions, Sasha or Grace, for me to get on there?
Are you sharing your desktop or are you sharing only your presentation? Because for you to change between screens, you have to share your desktop. It's the first option when you start share screen.
Okay, thanks, Grace. Let me just pull this back up again.
You're doing great, Gil. It's 2020, so we're all used to a little challenge.
It's really a lot easier to put in a femoral venous line than this. It's so I have to, here we go. This should work. Okay. So just to get used to the system. I see a number of people have already logged in. So this is just a test to see who of the panel was born in Chicago. And you could have more than one answer. It looks like we have about a third of the people have answered. So people are still logging on. Okay, a few more people. Axelrod is catching up. More people with Stephanie. Duncan, nobody believes, or 5% of the people believe you were born in Chicago. So those 5 have never heard you speak. I'm quite sure with a much more intelligent accent than any of us born in America. And just so we can move on to the next question, would the person who's from Chicago identify themselves?
That would be me.
That would be you, Paul. Welcome from Chicago. All right, the next question is, which of the panelists here was born in Boston? You can, if you're on your phone, you can click advance to next slide. And that's going to be important as we move to some of the other slides. All right. 31 people think that I was born, 41 people think that I was born in Boston. They may be right. We're up to 85. A lot of people think Stephanie was born in many different cities on the East Coast. All right, I'll wait till we get about 130 responses here. Will the person who was actually born in Boston identify yourself?
That's me, Gil.
That's David Axelrod. I was born in Philadelphia, and I'm a Philly fan all the way. And then the last test one here is which of the panelists or multiple panelists were born in Sao Paulo, Brazil?
Everybody has listened me to speak.
Because the swimming pool.
The swimming pool may have, but the swimming pool is in Portugal right now.
Yeah, this is Portugal. This is vacation.
Now, this is a trick question because we actually have two panelists that were born in Sao Paulo. So if you want to vote for a second person, go ahead.
Yeah. Laura told me that.
I didn't see if the panelist was on yet. If you're on, could you identify yourself? You may have to unmute. Nope, she's not there. So Stephanie Fuller, who's a cardiac surgeon at Children's Hospital in Philadelphia, was also born in Sao Paulo. I don't know if you knew that, Grace, but
Laura told me that the other day.
Yep. Okay, so people should know now how to work the system. So let me just ask a few identifying questions here. Use 3 words to describe the morale in your CICU. Whatever 3 words of how people work together, of what it's like in a usual day. That's not a good start. Let's hope that we get some additional words, and you can write the words in English if you can. Write them in whatever language you would like to. We're getting a few more coming in here now, as you can see. And I'm going to talk a little bit about this in the next couple of slides, because if we don't get this right, it's not really going to matter what medicine to use or what monitoring to use or anything along those lines. Some words continue to sort of come through. I like particularly we're seeing team and teamwork, but also challenging, stressful, hardworking, busy, frustration. I love the word clouds. And they give you a pretty good sense of what people are feeling on a on any given time. Wow, OCD was on there. That was an interesting one. I like that.
Right, sarcasm. That's pretty telling.
Sarcasm. That's probably from Texas, don't you think, Paul? Adrenaline. I like that. All right. The reason I put this up here is this is another word cloud. This is from 4 weeks ago when we had a PCICS one. You don't have to answer this one, but 2/3 of the words that were on this word cloud were negative in connotation, which is what made me sort of go to doing another slide. And I'm going to count that up, and we're going to be publishing this work. Grace and Sasha and I are going to be publishing our experience in cardiology in the young. I want to know how many people on this. This is a postoperative type session, and I'd like to know if people have joined the Pediatric Cardiac Intensive Care Society. It's a fantastic society that is really looking to expand internationally. The website is up there. 90% of us, it looks like, either are or would like to learn more. Maybe 10% don't work in cardiac intensive care unit. I would encourage you after the session to log in to the Pediatric Cardiac Intensive Care Society.org for some important information about our meeting in December, which looks very, very exciting. Jill, did I see you on the call? I wasn't sure because I only have one screen working.
Here.
Yeah, if there's anything that you want to add about the PCICS or membership at this point, please go ahead.
Yeah, that's awesome. Thanks, Gil. Registration for our meeting is now open. The meeting will be virtual in December. The meeting will be virtual, and there's $100 off for members, and it turns out that the membership fee costs $100. So if you are not a member and thinking about joining our virtual meeting in December, then you should definitely become a member first, and then sign up for the meeting. Like Gil said, it's a great program. The program should be online as well, so you can take a look at that first, but join us, it'll be fun.
Yeah, the website is fantastic too, with a lot of lectures like these in Basecamp. So again, I would recommend people take a look at that. All right, so I'm going to go back to the presentation if I can figure out how to get back to my slides here. That's always the challenge. And you say I should use desktop, huh? Okay.
If you use
There
your
we go.
desktop, you can share any screen that you have open.
So you should see a Blackboard now.
Yeah, welcome back.
Yep.
Welcome back. Okay, hi everybody. Looks like we have about 355 people here on rounds, so this should be interesting. I've said on a number of rounds that the cardiac intensive care unit at times can seem like the funnel of discontent. And I think many people would describe that even on days when it works well, and most units are stressful. And authority gradients are present. They have to be. They can be steep or flat. But as opposed to a NICU or a general PICU, the cardiac patients have multiple stakeholders, especially the cardiologist, cardiac surgeon, intensivist, advanced practice providers, nurse practitioners, bedside nurses, fellows, residents, anesthesiologists, echocardiographers, et cetera. That's unique. It's uncommon to see this many people involved in basically every patient in the cardiac intensive care unit. And in also the intensivists, the advanced practice providers, the bedside nurses, and the fellows and residents change on a frequent or daily basis, which for the people that are there through the longitudinal stay can get frustrated with what we just talked about this 48 hours ago. Why are we still discussing this? This is expected. This is normal. These are great people trying to do a really good job, but the challenges have to do with information transfer. We all want to be right about what we do. Most of us who work in this field are passionate. We're smart. We all have an ego. Some are a little bit more challenging than others, and that's cool. That's all right. But we all have to come to this being knowing that we all want to do the best thing for these patients. It's this type of conflict that can get in my opinion anyway, that can get in the way of any of the postoperative care maps that we may talk about today. We all want to be right. Nobody wants to think they've been doing it the wrong way. And this is a great quote I like about the difference between a discussion and an argument. An argument is to find out who is right, and a discussion is to find out what is right. And more often we slip into the who is right rather than the what is right. And if you all haven't listened to some of the work of Brene Brown, who talks a lot about vulnerability and other issues, I love this quote, which is, we're not there to be right. We're not in the ICU to be right. We're in there to get it right. And that's important. I think we will do better if we talk less and listen more, and actively listen, not just wait for our chance to speak, but be really willing to talk about what other people are like. We have come from different training programs. Let me pick Brian Siegel as an example, who is a well-trained, double-boarded pediatric intensivist. He trained as a pediatrician, right? So he trained to be thoughtful. If there's a differential diagnosis, he goes from A to B to C and then thinks more about D and figures out how to stop this runaway train. However, if we move to Dr. Agati, who is a surgeon, surgeons are very direct at figuring out how to stop a runaway stage. We come at this from different places. I may think that I'm being very thoughtful and that my surgical colleague may be dogmatic or non-collaborative. But there's always a flip side to that, right? The surgeons may think the pediatricians are indecisive, and surgeons may be much more direct. They're trained to solve a problem and to solve it quickly. One is not right and one is not wrong. We just have to recognize we come at this from a different place, from a different lens. And rather than reflexively disagree with other persons, and I've seen this in many intensive care units, to be thoughtful, to listen to the other person, to be curious about what they have to think, and to validate what they have to think, even if you have a different way of thinking about it. I hope Stephanie is on. I know that she had a case this morning. Stephanie and I worked together for many, many years and had just a terrific relationship because we were able to listen to each other and really respect the other person's viewpoint. I'm going to open this up to the panel for a little bit. Duncan, maybe I could start with you. And any thoughts on the human factors here with with how this works?
Yeah, it's always good to go first. The human factors actually are something that we all deal with on a daily basis, whether we actually think about that or not. I think you mentioned authority gradients. And whilst, yes, there has to be an ultimate authority in terms of making a decision, that the best decisions in that complex multidisciplinary team, I think, are best arrived at by having, a forum where there's discussion. So a multidisciplinary team meeting as part of the structure of complex decision making. That's certainly key. But also, I think, intensive care units at the end of the day, we care for patients who've got heart disease, but they also have multiple other things going on. They may have, a congenital renal issue. They may have a metabolic problem. They've got nutritional challenges and so on. So we ultimately have to try and be the general physician, the family physician, to corral all the different opinions and focus them on solving the problem, which is the baby with the heart disease.
Thanks. I'm not gonna call on everybody, of course, but let me ask you one more question, Duncan, if you don't mind. What was it like for you to go from the Brompton to Doha? What things sort of were obvious differences in very culturally different place? Probably staffing is different. And what's similar and what's different?
Okay. Culturally, yes, it was different because clearly it's an Arabic country. Having said that, I'd have the privilege, the pleasure with working with many Arabic families and both in my NHS health service practice and my private practice in London. So actually, surprisingly, that wasn't necessarily the biggest challenge. Biggest challenge for me, Gil, was learning to work with Cerner and working with basically in a hospital that was developed on an American model. I've got to go QID, BID, and learn a whole load of terminology. That was a challenge. But different team, different systems, and until you can work your way around the system, it's actually quite difficult to be on top of your game. It takes a little while to settle in.
Jai, what's it like up in Sick Kids? How would you, and we have to be honest with each other, it doesn't always work well. How at Sick Kids are some of these interpersonal things dealt with? Because every unit's got them.
That's true. I will say, and this is actually not just me being a cheerleader for Sick Kids, I find that the hierarchy here in Toronto is the flattest that I've encountered. There's a pretty robust culture of talking about patients. And that when I say talking about patients, those are sort of collaborative conversations that occur across the spectrum of care. They start with everyone talking about the patient at med-surg. We have a collaborative rounding model. And so we typically have the staff surgeons on morning rounds with us. And there's an active conversation about what's happening with the patient at the bedside. And then when the patients are discharged, we talk about patients again in our performance rounds format. And it's a very nice way of kind of creating if you will, a continuous story arc about the individual patient. That doesn't mean that there isn't ever no disagreement and no conflict. I think that's because everyone is passionate, and as you pointed out, everyone has a slightly different perspective. There needs to be a means of resolving those conflicts. And so I was going to echo what Duncan said, which is that even if you have a very flat hierarchy, there has to be someone who identifies themselves as the person who ultimately makes the decision if there are competing imperatives, and gets everybody on board with that decision.
Thanks, Jai. And maybe just one more, Paul. And we'll sort of move these around, but Paul and I are good friends, equally sarcastic and equally blunt and honest, I think. And Texas is an interesting state. For those of you not from the United States, it's sort of hard to describe. It's sort of like Florida with a cowboy hat on it. Sorry, Paul. You have an entire building, many different silos. There's got to be great parts about that. And I would imagine some friction. What's that like? And I don't mean to sort of call out Texas Children's, but how do you, as a director of a program, deal with those sorts of things?
We embrace it, honestly. And I think that, we touched on it just as you went around the panel. There are cultural differences in the way we're brought up, and even within the US. The thought is that it's Texas, so if I disagree with you, I just pull out a gun and shoot you. It's not too far off. It's still better than Florida. But, some of the things is we have to understand that we embrace it. People within an ICU community, I think, got into it because we enjoy team sport. We enjoy the fact that it's us against the world, and what happens within the walls of the ICU is us. That's what drew us into this. Understanding, as your first slide showed, that surgeons, it is the Wild West. They were taught to be independent. They were taught to be the quarterback at all times. It would be silly to think that I'm going to change that culture, because I've long since in my career given up on things that happened to people before they were 18 years of age. I can't control your upbringing. I can only control you at work in terms of your attitude. So I think it's embracing it, and embracing a little bit of friction, but friction in a professionalism standpoint, and embracing the cultural differences, and then trying to figure out a way to leverage those into another type of a team that works well together. I think that's got to be a reality.
Yeah, and it's not, at least in my opinion, it's going to be there. Even in a place as flat as where Jai works up in Toronto, it's inevitable. We deal with very sick, complex kids, and to act like it's not there can sometimes be more hurtful than to try to work it out.
But one last thing, though, I will say is, still in the end, there's absolutely no excuse for being a jerk, right? No matter how bad your day is, there is a line that is clear that says, no, we are going to be professional, and we are going to be courteous and kind to each other. And if that's the basis, then the rest of it works.
Hear, hear. That's a good segue into my next slides, I think. Right now, my slide should still be up, right?
Yep.
You see the 9 Bs?
Yeah.
These are the 9 Bs that I think are important for us that work in intensive care unit. And this is, I just made these up, but I'm curious what you think. We should all be available, empathetic, intentional, transparent, and be nice is right there in the middle. There's no reason not to be, as Paul just said. Be accountable for your actions, be mindful of other people's opinions and respectful, and importantly, be open-minded. Many times in the stress of what we do, we can forget these things. And, especially all these people that gather around to care for these babies. We are people, bottom line. We're not systems, and we're not Cerner, Duncan. I mean, the bottom line is we see humans, and we need to work with this. I would love to one day give a talk all in memes, but I found 4 that I really like. My grandmother, I had a Yiddish bubby who used to say to me, we have 2 ears and 1 mouth so that we can listen twice as much as we speak, which I love. Another thing from one of the programs, does this need to be said? Does it need to be said by me? And does it need to be said by me now? An acronym for that is WAIT, which is why am I talking? And then the Dalai Lama said, when you talk, you are only repeating what you already know. But if you listen, you may learn something new. And then finally, one of the best jazzmen ever, Miles Davis, said, if you understood everything I said, you'd be me. And all of these come to the point of that I've certainly not done well many times, which is I'm just listening for my chance to speak and to ask the opinion of my colleague. Well, what do you think here? And I'll be honest, the older you get, the more senior you get. Sometimes that's more challenging to do. And I try to call myself out on that. Okay, we're going to make this simple. There are 4 rules and 6 types of heart disease. And if you take those 4 rules and 6 types of heart disease, you can form a structure on how to approach the patient. The 4 rules I've modified from the 3 rules of my good friend and colleague, John Berger. John is an amazing intensivist. He's been working at Children's National for, I think, 20 years. And his first rule is know the anatomy. Know the anatomy because it predicts the physiology. You can't just, I recommend you don't say, this patient has had a Fontan. Knowing the specific anatomy is particularly important. The second rule is that postoperative patients have a predictable pace or a predictable path of recovery. And that's what we're going to spend time on today. And then the third rule, a little sarcastically, is if rule 2 is not true, refer back to rule number 1 so that you can then understand the anatomy. And I've added another one, which is, to me, what I was taught and what I think is the most important thing, that if the patient is not doing well and you know their anatomy and you think what their predictive course should be, evaluate the diagnosis and evaluate the repair. For people that don't deal with congenital heart disease frequently, it can be a little overwhelming, or if you're working in a mixed unit and you haven't trained in cardiology, the cardiologist very commonly will use far too many abbreviations and try to simplify a very complex field. So I'm again going to try to simplify something. There's Andersonian types of defining heart disease and Van Prague, and I'm going to make it simple with 6 types of heart disease. You can have, the baby can have holes, the baby can have things that are small, there can be missing parts, there can be narrowings, there can be leaky stuff, and then there could be parts that are just not attached good. And you could take all of congenital heart disease and put them into those 6 categories, either alone or in isolation. And as you're doing your postoperative evaluation, you're going to say, were all the holes closed? Were the missing parts attached appropriately? Does anything leak? And I'm going to get into some more specifics about that. I mean, I say it in jest, but it really can be made pretty simple to use those 4 rules and to think about the 6 types of heart disease. Why understand the anatomy? Well, one needs to understand the abnormal size and alignment of the ventricles and the great vessels, what might be missing. I think it's particularly helpful for the trainees or people who don't work with this for a long period of time, the bedside staff, to have diagrams at the bedside. In our unit right now, they're done by our medical fellows do the cath diagram, and then that's if they've had a catheterization. If not, we modify that for what was done at the bedside, and it stays there and moves with the patients. It's important for us to understand the surgical procedure in detail, and we're going to talk about handover in a little bit. It's not sufficient in my mind to say, baby had tetralogy, what did you do? I fixed it. That won't help us at 3 o'clock in the morning if something goes wrong. And the 3 most important questions are, were all the holes closed? Is there any residual or new obstruction to pulmonary or systemic flow? And have the loading conditions of the heart been changed? And knowing those things are going to help you with 95% of postoperative management. Then, actually, I'm going to skip through this. I'm going to leave this slide up just to, in the interest of time. So this will be on the recording that will be on our YouTube channel. So all of these talks are saved on our YouTube channel. I gave a bunch of examples here, not to go into the detail on time, but if you want to look at these types of slides, you're welcome to use them, share them, whatever. This is all open source. And for reasons that I don't know, the slide is doubling. Okay, so postoperative, what are the new loading conditions? Okay, so if I've seen a tetralogy baby who's now been fixed with a transannular patch, there's a new volume load on the right ventricle and a decreased pressure on the right ventricle. Then is the systemic cardiac output normal? Well, we hope so, but is it normal because we are on a lot of inotropic medication or a little bit of inotropic medication? And then if the patient's cardiac output is not normal, or they're on escalating doses of inotropic support, the first question is why. The answer is not epinephrine deficiency. One needs to know what's going on with the repair. And importantly, you don't just start in the operating room. Did the cardiologist make a complete and accurate diagnosis? Was an additional VSD not able to be seen? Was a branch pulmonary artery narrowing not able to be seen? Is there myocardial dysfunction? due to an acute change in the loading conditions, or more importantly, was there difficulty with myocardial protection, for example, because of valvar regurgitation? Looking at the coronaries, looking at the conduction system, and is there tamponade physiology? These are the ways, at least I think about patients. After we talk about handovers and whatnot, I'm going to ask a couple of the panel members to think about the way they approach the repair. But are the holes closed? Are the narrowings opened as they're supposed to be? Is there any residual obstruction? What's happened to the conduction system? What's happened to the coronary arteries? What is the myocardial function like? And that assessment of the repair happens on a daily basis, as well as all the rest of the things that we have to do in intensive care, such as perhaps have a patient on mechanical ventilation. Many have said this before me, and that's good postoperative care begins in the operating room. Therefore, if we think we're going to have early extubation, it would be helpful to know that to help guide anesthetic management so that there's not a huge dose of fentanyl, for example, at the beginning of the case. Want to know what types of monitoring catheters would be helpful, not only to come off bypass with pressure measurements that would be helpful, but for the team in the intensive care unit to help treat that patient. Adjunctive pain management, spinal blocks, local injections of anesthetics, all of these are helpful. And then I think what was field changing really in the mid to late 90s was the ability to evaluate the repair in the operating room with a transesophageal echocardiogram. Especially for those of us who are a bit older in the field, we did not have that opportunity. We had what the surgeon felt the repair was like, as well as monitoring lines and anesthetized patients to do mini heart caths in the ICU. Okay, I'm going to talk about handover, and then we're going to go to the panel and do a little bit of questions. But probably the first crucial node that happens in good postoperative care and setting up a systematic approach is the handover. We talked a little bit about this and how some of these techniques got started at Great Ormond Street in London, looking at a Formula One strategy. And these have been modified in various different places. And everyone stays and everybody pays attention for the following questions. But before I say that, there was a time when the attending talked to the attending, the surgical fellow talked to the fellow, the OR nurse talked to the bedside nurse, and it was like the blind men and the elephant all seeing something different. Everybody stays together and hears about the underlying heart disease, the additional medical issues, what the airway was like, diagrams, as we talked about, assessment of the repair by the surgeon, and transesophageal echocardiogram. And this is where honesty is particularly important. I'm not really happy with the bleeding. I'm not really happy with the left coronary, or I really think everything went well, etc. Any problems with bypass cannulation? What were the times? What was the myocardial ischemic time? Evaluation of the patient after transport. What are the numbers on the ICU monitors that are maybe different than what was coming off bypass? The first blood gas while the team is present and the anesthesiologist and their team are there, so we can get a sense of lung compliance and gas exchange. And then at the end, one person, as Duncan was saying before, it could be the fellow who's going to be taking the case or the attending intensivist, closes the loop by going system by system, reevaluating the repair, what's the current physiology, and what to be expected in the next 12 to 24 hours from the intensivist and the surgeon. This process is crucial. It should not be rushed. And although it may seem like it takes a long period of time, studies have shown that it actually saves time in the long run. Now, here's another thing about handover. Let's say we get a case back and it's 2 or 3 o'clock in the afternoon. Everybody there may know all the things we just talked about, but in many intensive care units, the staff changes somewhere between 3 and 7 p.m. It's different in every center, of course. How do we repeat that information for the evening and night shift? What's the system with one does that? And we're always in conference, in our work, in our notes, we're always balancing completeness versus efficiency. And it's a different sort of look, whether you are the attending senior physician or you're the bedside frontline handoff. from my perspective, right up front, I need to, and my colleagues, my attending physicians, always need to know the anatomy, the preoperative physiology, the surgical procedure, and a daily assessment of the repair. Some of my colleagues in the intensive care also want to know all the medications, all the laboratory values, the fluid intake, the nutrition, et cetera. Others do not. There's no right or wrong way to do that. It's your comfort level with that. But the bedside and frontline staff must be meticulous to all of these issues. All right, so I'm going to open this back up to the panel before we get back to the questions. So what did you most disagree with and why? What additional factors did I miss? So what's also, from your perspective, important up to and including arrival in the ICU? And any additional rules or guidelines that you routinely give your trainees? Let me start with David Axelrod, who we haven't heard from yet. David's out in San Francisco. What did I miss? What's different? Give me some ideas what you think we ought to talk about in addition.
Thanks, Gil. As always, fantastic talk and lots of really important issues, I think, for ICU care. I don't know that I really disagreed with anything. I'd probably modify one word there, which was in your 9 Bs. Instead of nice, I actually see it more as kind. And so, and the important difference there for me is I think, especially in pediatrics, and maybe based on location, at least in my experience, being on the West Coast compared to having grown up in Boston, nice is really different. I mean, nice sometimes actually can be a problem in that it doesn't allow teams to actually, transmit difficult information, and you can still tell someone that that they've made an error, or tell a parent that their their child isn't going to make it, which may not necessarily be nice, but you got to be kind, and so that would probably be the one that I would just briefly mention.
Thanks.
And I actually
wanted to ask. I'm sorry. Go ahead, David. I apologize.
No, I was just going to say I do. I love the one about you have 2 ears and 1 mouth and use them in that ratio, because I actually have a slide that I talk to our fellows and give them that information too.
Well, my grandmother would be very happy with that. Jill, you're in a different position as an advanced practice provider. What are your thoughts on sort of a structured approach? How do you approach the patient? You walk a fine line between the bedside staff and the attending physicians and the surgeons. What would you agree with, disagree with? What are your thoughts on what we've talked about thus far?
It's actually funny. We were talking about this very topic this morning. I think we spend a lot of time in education and preparation and orientation talking about defects and what will go wrong and what to expect from a negative side. But in an ideal world, none of that should happen. And we don't spend a lot of time talking about what the trajectory should be, what to expect. And I think that that's something I've realized only recently in my 12-year career, is to try to, figure out the expected trajectory and when you have strayed from that. So I think spending more time talking about what you would like to happen and what should happen has really made my life a lot easier and makes the whole job make a lot more sense.
Thanks. We're going to, the next set of slides after our poll, we're going to get into that. Peter, what are your thoughts? Is there any huge difference in sort of the way you approach your assessment of the repair? And what are sort of, if I were to say, what are the 3 to 5 key things that you teach your trainees and your bedside staff?
Well, what I typically tell my trainees and what I prepare for myself is that I say, I totally agree with you. You have to know the anatomy. You have to know the trajectory. And I think there are basically 2 problems that we should prepare for. One is a general problem, postoperative, low cardiac output syndrome, bleeding, arrhythmias. Be prepared for those. And then Secondly, prepare for lesion and operation specific problems that might arise, and make sure that you're prepared for those. So that's how I try to approach the patient at that time, and then try always stay ahead, if it's possible, of what's going to happen.
Thanks, Sasha. You're the surgeon surrounded by 9 non-surgeons. What is your approach usually? Don't mess it up, or what?
I think that I want to underline that in your B slide, you must be respectful, must be the first point. Because what we miss probably between the team, if no one respects the other one, or one anesthetist or one intensivist doesn't respect another one, this make a very bad sense of the team, and the atmosphere is not good. It's not easy to change the position of the surgeon, the anesthesiologist. We pay probably in Italy the fact that our intensive care is managed by general anesthesiologists that became in the course cardiac anesthesiologists. We don't have a real role of intensivist or pediatrician who is taking care of congenital heart disease patient during the ICU stay. So as I learned from you, you have to work on building the team rather than to kick the team. So I don't want to add nothing, but I think that respect from professionals is, and of course senior, is the most important point to build a quiet atmosphere for grow, and then kind and nice, all the things.
Thanks, Sasha. I'm going to get to the other panelists. We're going to go till 1 o'clock Eastern time, if people can stay. Is there something as particular? I put that slide up there that should still be sitting there, because we all have blind spots, and I know I do. And if anybody else on the panel can think of, up until the point they arrive in the ICU, we're about to talk about the first postoperative night and then the pace of recovery. Is there anything else you think is important to add to this? Especially Brian, I mean, you've just come out of training and all of a sudden you're the person making the decision. What do you wish you had heard in those 5 years that you're like, I can't believe Gil didn't tell me this? I mean, what would be on that list?
Well, so I can't disagree with any of your rules, because both you and Dr. Berger trained me, and I had those hammered into me. I would second Jill's point about it's a lot harder to learn the expected course for all of the particular lesions that we take care of, rather than memorizing all of the possible complications. And so while during training, 5 years sounds like a long time, and you may see 50 tetralogies, and by the end of those 5 years, you're like, I don't want to see another one. On day one of being an attending, when you see a tetralogy, all you're wishing for is that you saw more of them in the safety of a fellowship program, and that you had a better idea of what the expected course would be in a perfect repair. So I think that's the big key, I think, to try and get from any of the training. And then the only thing I would add, I think, to evaluating the repair is that it doesn't necessarily mean you're sending the child to the cath lab immediately, or that you're getting echoes immediately. I think when you taught me this, is that just having an explanation for why someone veers off the course doesn't mean you have to do something immediately about it. It just means that you have to change what your thought process is and what the expected path for that patient is, so that you can kind of adjust your expectations and set a new path for them, and hopefully that they follow that path.
Thanks, Brian. I see Paul and Jai have their mics off. We'll do it quick. Anything to add? Paul, you always point out what I forgot. So
not yet. And unfortunately, I'm going to have to go as soon as I make this comment. So I should probably, on the way out the door, just make some really nasty comment about you. But no, the reality is, the only thing I disagree with is one thing you said, which is the details in terms of handoff. And I think it ties in with what's just been said. I think there's so much information that gets thrown at every team and every individual at the team. So every single moment of every single day in an ICU that we lose sight of the big picture. So I'm trying to figure out how to set it up so that you see the big picture. If there's a trajectory that's supposed to be good, why bother getting wrapped up in the details until something goes a little bit wrong and then go after those details, or else you lose sight of that. This is the way it's supposed to go, the expected trajectory. And I'm really struggling at this point in my career to balance those two out, to be a detailed person, but also to just see that big picture and not lose the forest for the trees.
Yeah, that's that. I put that up there. Those words I heard somewhere else, I forget where, of completeness and efficiency, right?
Yeah.
It could also be completeness and big picture plan.
Right.
You know, and I think the more senior you get in the authority gradient, the more you're responsible for the overall sense. And Brian, as you're sort of moving through your career now, that's where that shift, you know, starts to happen. Any last comments? Because we have a few more things to go over.
I
just
make
need to
brief
comment.
comment
Okay,
there?
sorry. Go, boss.
Yeah, one thing that we did in my previous place in London was what we called anticipated care. So at the end of every morning handover, we'd identify the patients that we knew were coming to us, the elective surgery and so on. And then so it's every day, routinely, the fellow would prepare the case just very briefly, 2 minutes presentation. What do we expect in terms of the general complications, you know, bypass, non-bypass? Is it a reoperation? Is there going to be bleeding? And then the things that Peter mentioned, the more specific, lesion-specific things. So it's basically doing what Peter was describing, but building it into the handover in the morning so that it was a routine part of what the team did. And the nurses who were going to look after the patients would be in the room as well. So it whenever possible. So it was a good way of getting the team on board, thinking about what the trajectory was going to be, thinking about what they were going to be looking out for in the first hours the patient was back in the ICU, even before the operation started.
Great, thanks. Grace, you were going to say something?
Yeah, I truly believe that the nurses are the stars of the ICU. And what I usually do after when I get the handoff from the OR and then the fellow or the hospitalist, they make the plans, I get the read back from the bedside nurse. So I think this is very important. So I need to be sure that she or he who is going to be the one who is going to be at the bedside all the time understood what is going on, what they should look for, what would be the triggers for calling us. And I think this is very important because even the most experienced nurse, when they are taking care of a post-con procedure on absence, for example, on that particular one, you can have a larger PFO and your RV could be worse. So on this particular case, your saturations are not going to be the normal saturation of a normal absent correction. So these details, we need to be sure that nurses understood, and of course all the team understood, but who is going to be at the bedside is very important that they know what they are looking at, what should be, and what should trigger them to call us.
Yeah, that's fantastic. I think the closed loop communication is particularly important, which is why everyone stays till that's done. We've all seen that situation where side conversations start to happen, and it's my job to be sure everyone is listening. We're going to go back to the poll. This is a little bit of a break. It's now, we're 1 hour into this. So you can either scan the QR code or go to ahaslides.com, post-op plan. And if I go to desktop, this is what Grace taught me, so it must be true. I should be able to now share this. Are you seeing the slides?
Yes.
Now we are back to presentation.
Okay.
Yeah, good. We are in the poll.
So you should be seeing 3 words to describe the current handoff of patients from the OR to the ICU in my institution.
Yes.
Is that showing up there?
Yes.
Great, thanks. So some, one-sided, brief. A few more. I think people grab your phone, see if you can pick up some other things. This is going to be really, as we look at a couple of different of the talks that we've given, it's interesting to see some themes that come through. Chaos, by the way, is one of the most used words in this question and other polls that we've taken from the audience. We've got about 130 of you are currently logged on. Again, it's ahaslides.com, post-op plan, all caps. I am encouraged that complete and organized and structured are now 3 of the larger words that we see here. So just take a few more seconds and we'll go to our next question. How many of you have a structured OR plan? Yes, no, or it's more like sort of, or it's more like a circus. Well, that's concerning. There's been some great things that have been structured, and I'm pleased to say that we are at the very early phases. Jill is on board here that we're going to hopefully work on a position paper from the World Society for Congenital and Pediatric Heart Surgery, the Congenital Cardiac Anesthesia Society, and the Pediatric Cardiac ICU Society on structured handoffs that will be evidence-based, and hopefully these sorts of slides have gone a long way to saying it's a necessary white paper. So look for that within the next year. Just for the physicians that are on this call, only the physicians, does your unit have a collaborative work environment? There's been some research showing that sometimes the physicians and the nurses and advanced practice providers and fellows and whatnot have a slightly different perspective. So it looks like 2/3, maybe a little bit more, will say absolutely or most of the time. So now nurses and advanced practice providers, would you say your unit has a collaborative work environment? I don't know how many we actually have on the on this. So smaller numbers of people who are answering the question. We had about 80 before. Now we're getting closer to about 20. The percentages are skewed a bit more to the right for the nurses and APPs versus now we're all in different units, of course, so this is not scientific, but this is what the research has shown is in general, physicians think the work environment is more collaborative than the nurses do. And again, that's open dialogue. That's the type of stuff that we, I think, can do a better job at. Let's do this one quick so we can move forward. Just going to take a little break, stretch your legs if you want. 2 words that describe why you take care of critically ill children with heart disease. And Grace and Sasha, you know what we've seen many other times. I suspect that this is what we're going to see in the word. Yeah.
Yeah. Fantastic.
Yeah, it's the challenge and rewarding. I've never seen money, but I've always seen challenging and rewarding. Now somebody's going to type in money, of course, but I've always seen these types of statements, which is, really, really encouraging. Thank you, everybody. I'll give 5 more seconds just to put a few more things in there. Okay, if you want to come back and answer these, you can. Very quickly, how do you identify your gender? It's fairly similar to what we usually get, unless we're on a surgical panel, which tends to be about 2/3 male. Okay, there's that. I guess Paul left, so we have to guess for where Dr. Kekia is. Right, excellent. And some people are about to go from the 40 to the 41 bracket. You just have to put yourself in for where you are. This also looks exactly like every other webinar, Grace, doesn't it? It looks that the majority of people, and I like this because when I see that the majority of people are in training or early career, it helps guide the direction that we plan the webinars.
Yeah, this
Okay. Next is, where do you live? And if I didn't get it right as to where you should call yourself on the bottom, I do apologize. I was so pleased to see about 9 or 10 countries from Africa represented. Even the Democratic Republic of Congo. One of these days, I'm going to try to break out North America and see where that goes. So certainly many, many people have, the US is the largest, like we had in terms of our registrations, but a large number of people after that.
Gil, you've got somebody in Antarctica?
I think that's where Paul went. I'm not sure. Or it came out wrong on the phone on the poll. What describes your daily practice? We're going to get back to our slides in about 5 minutes, but we have some interesting things that I think will help direct where we go with the next part of our panel. Again, there's 338 people on the webinar and only about 144 have logged on. So especially for the next part, if I could encourage you to either scan the QR code that we had before, grab a phone, get on another device, and log on to ahaslides.com/post-op plan. See if we can get a few more people logged on. So the majority of us on today are pediatric cardiologists, cardiac intensivists, or other. Okay. This helps with sort of how we're spreading the word. Again, just very quickly, how do you hear about this webinar? If it was from more of one place, just please let me know. Sasha does and Grace do amazing work on email. Surprisingly, we don't get nearly the amount of attention I thought we would through social media outlets. Maybe we can start to figure out, Jill, you're the head of social media for the Pediatric Cardiac ICU Society, and Grace for the World Congress of Pediatric Cardiology and Cardiac Surgery. So we're going to have to learn from this because email may or may not be the best way to move forward. Okay, so now we're going to get into a couple patient scenarios, which we're then going to talk about. Okay, so there's 146, 147 of you logged on. I would really hope we get as many of you as possible for this part. After an arterial, again, just to give you the link again, ahaslides.com/post-op plan. Yeah, more people are coming in now, which is great. So what is your typical medicines that you use? And this will be more representative of real world experience versus what's out there in the literature. I find this. So right now, just to give you an idea, if you look down on the bottom right of your screen, I don't know what it looks like on the phone, 115 roughly people have already responded, and 122. So over 90, maybe 95% of babies that have had an arterial switch operation receive milrinone, and maybe 2/3 epinephrine, with a scattering. I didn't put phenoxybenzamine on here, which in retrospect, I will think about for other ones of these. And I've been to some units recently that are routinely using nitric oxide donors, such as nitroglycerin or nitroprusside or nitric oxide, theoretically for the coronaries. As in always, we always do this type of thing. We'll talk a little bit about always and never in just a little bit. So again, out of 130 or plus or minus of you, almost everybody uses milrinone and a great majority epinephrine as well. And dopamine, which I think Andrew Reddington recently called a poison, is now much less in use. Let's move over to after repair of obstructed total veins in the neonate. Our patients typically receive. You can advance your slide on your phone. Okay, so many more of you have these patients under neuromuscular blockade than the arterial switch, but surprisingly only, to me anyway, only 25% of the respondents have the patients paralyzed on neuromuscular blockade. Same inotropic cocktail of epi and milrinone for most of you, and a higher percentage of nitric oxide, of course, in obstructed total anomalous pulmonary venous return. So it's not as universal as I would have guessed. It's less than 50% for the use of nitric oxide, which it's interesting. I've worked in a number of different units, and you get used to the dogma of this is what, quote, we do. And it's so different in different places. We have so much to learn by sharing best practices. All right, so that's about 120 of you. What about common arterial trunk or truncus arteriosus? So here's a baby. It's had an RV incision, an RV to PA conduit, VSD closure, longer operation in many cases than the last ones that we just talked about. People have stock in milrinone or something, or gilrinone. Okay, we can see common themes of epinephrine and milrinone, and then more selective use of things like nitric oxide and neuromuscular blockade. And I will put in a Norwood operation. Not everybody takes care of Norwood patients, but let's see what this looks like. It's a quarter after, so we'll have our next 45 minutes for going through the last two parts of the talk. So many more patients have neuromuscular blockade, but not everybody. Milrinone, of course, which has been studied in biventricular hearts, and pharmacokinetics have been done in hypoplastic left heart syndrome, has not been approved by the Food and Drug Administration in the United States for use in this patient population. But like many things, we use it off-label. Epinephrine is used much more commonly. All right, and I think there's one, if I remember correctly, there's one last series of questions. Okay, so now I'm moving up to the infants. VSD. We've just done 4 neonatal operations. Let's do 3 infant operations. Hopefully you're not bored. We're going to do these relatively quickly, so be ready to go. So uncommonly to have neuromuscular blockade, only about 4 to 5%. Most on milrinone. Just a few on any more significant inotropic support over there on the left. I'll wait till this gets up to about 115, 120. And then we'll move to our next infant operation, which is tetralogy of Fallot. Let's talk about an 8-month-old. In the US, those numbers are a little bit lower. Outside the US, they're a little bit higher. Let's see what people use here. And of course, there's other options, and we're not going to get into all of those. But over the next few slides, when we talk about things like delayed sternal closure and the first night and then the first 5 days after surgery, these are important issues to think about what's used in your unit. Okay, I'm going to move to the next one, which is a misspelled superior cavopulmonary connection or a bidirectional Glenn shunt, cavopulmonary shunt in a 6-month-old. What are your patients receiving after that? This very little variability here. Hardly anyone has neuromuscular blockade. Milrinone seems to be used in it's probably part of the admission orders in most cardiac ICUs now. There are some units, I look forward to the study of nitric oxide in the bidirectional Glenn. There have been small single center studies, but I really look forward to some larger multi-center trials of this. Okay. And then the last question I'm going to ask about is delayed sternal closure. So in your unit, if a baby has a neonatal arterial switch operation for transposition, what percentage of your patients have elective delayed sternal closure, not the one who's bleeding, not the one who's on 6 inotropes, but your basic your basic arterial switch operation. I always love when I see slides that have the same numbers as essentially always and essentially never. We clearly can do better when that's our skew, right? There must be some better ways to answer that question. So the majority are less than 50%. That's interesting. Let's move to same question, but how long do you normally keep a kid, the same operation, excuse me, how long do you keep a neonate with an arterial switch ventilated on average? And that counts the delayed sternal closure day, of course. So early extubation, or what might be considered early extubation, depending on your criteria, only in 5 to 6% of the patients. And certainly the overwhelming majority within 4 days. Okay, total veins, delayed sternal closure, much rarer operation, so many may not have as much experience with this, but how often do we have elective delayed sternal closure in this neonatal operation? Pretty similar. You know, one could argue that these kids could be more labile than an arterial switch patient, but many of them get closed. Another area of that's right. So for all the trainees on here, these are areas that are ripe for investigation. There's dogma in most institutions, but there's also data that can be collected for this. Okay, how about the average duration of mechanical ventilation? And when we get into the path of recovery, and I'm glad you said this, Brian, when we start to talk about trajectories, these are kind of things that are pretty unit specific. And we'll talk a little bit about what to expect. And I don't know if Paul had to leave, but I'm going to quote him when we start to talk about monitoring and how to make decisions on what to do about patients. So again, most of these kids, slightly longer duration for obstructed total veins, but most within 3 to 4 days. Truncus arteriosus, delayed sternal closure, 3 more of these. Thank you for all being patient. Interesting. So here we got an RV to PA conduit sitting right up under the sternum. And many of them have the sternum closed. And I've heard many dogmatic people talk about how this operation in particular should have a sternum closed. And equally dogmatic people talk about we never close it. And then the last question on arterial trunk or truncus arteriosus. How long do you keep them ventilated on average? We're coming up with pretty much the same thing for our neonates, or at least the 3 biventricular neonatal operations that we've talked about, where a half or more are closed and most kids are ventilated for 3 to 4 days, sometimes a little bit longer. These are good guidelines. You know, we've got so many different centers that are represented. Now we've got Norwood's. How often, these 2 slides are the last 2. So we've got essentially always and essentially never have an open chest. This is probably the one that I've seen the most frequently done on a routine basis, which in various centers is an open chest. But, you know, less than 25% in almost half of the people here. Last question, but I'll wait just a few more seconds for people to get their answer in. We've got 92 of 125. People are stretching, I hope. Get ready for the last bunch of slides, and then we'll open up the panel. And then there's a lot of variability in this one, but how long on average? I know sometimes it seems like a really long time, but there's data being collected on this. How long are your babies that get a stage 1 Norwood operation ventilated for? You know, obviously you can't extubate early if you use an open chest. On the other hand, if you don't have an open chest, you may be reopening the chest. So many areas to look for. So it's encouraging to see that, you know, a little less than 2/3 have ventilation for a week or less. The data in some of the larger cohorts, I think, is 8 days for the median. But as I talked about before, it's the outliers in this group in particular. It's not the average, but it's the ones, how many percent of patients stay in your unit 2 months or more. Okay, so now if I do a share, I should be able to, let me close this. While I'm getting my slides back up, who hasn't, there's somebody who hadn't talked on the panel yet, but let me ask Peter what you think of all this. So we're sort of skewed a little bit to the US, but what are your thoughts on what we've talked about so far?
I think I've done a similar sort of poll a few years ago because I worked in a unit before where we used routine dobutamine, and then I came to a unit where we use milrinone like water. Everybody gets it. And the literature then, my poll then also showed that everybody uses milrinone, and I don't think there's a whole lot of evidence for it. Doesn't mean it doesn't work, but it means that there's a lot to learn still, and I don't think it's for everybody, for certain children. And it would be, and I think it's very good to look at the specific operations and then make a plan with your team as to what you think the approach should be. What inotrope do we use? What sort of fluid status? When do we do echo? When do we do a cath? When we think that something's going wrong? So plan out beforehand, so everybody's on the same page. That would be ideal. I'm not saying that it's how it works.
It's terrific. No,
but
I'm really glad you're saying that.
Goal.
At the end of this, I'm going to propose a few care pathways, and it'll be interesting what people have to say, because I think that's a really good point, is to put it out in advance. So you say, okay, if we get to this point, we're going to do X, Y, or Z, rather than trying to make a decision each time. I like that. Yeah. Sasha, what do you think so far? Did any of that data surprise you?
No, it means I think as Peter say, probably we use milrinone too much. Sometimes also in patient that doesn't really need, but because we don't have a real acute clear effect of this therapy. But in our unit, we used to do very low dosage of dopamine, and we associate milrinone. And if the patient, of course, doesn't work, we add epinephrine. But we don't use dobutamine, we don't use other inotropes.
It's, go ahead, Sasha, I'm sorry.
Sorry, no, sometimes we like, the anesthesiologists, they like phenoldopan for vasodilatation.
I think people forget, we didn't make a big enough deal about it in the milrinone study, in the Primacor study. Only 25% of the patients in the placebo arm developed low output. So that tells me that we're using milrinone, and 75% of the patients don't need it. But I don't know necessarily who they are. So it's become one of those drugs that's used so frequently. Anything that's very different from the panel before I get on to the last set of slides? Thanks. So I should be sharing my slides now.
Just need to go to presentation mode. Now it is perfect.
Okay, great. So we've talked about this. The assessment of the repair, the amount of inotropic support, can it be weaned or stopped? What's the interaction between the ventilator and the repair? If you're hypoxemic, is it because of a planned intracardiac shunt or an unplanned intrapulmonary shunt? And then all of the things that we are using to keep the patient comfortable. Every place has a different way of doing this. I know that in many general pediatric units, certainly in neonatology units, they have this plan that goes like this, where you start off with fluids and electrolytes and move your way down. I think a different approach should be taken following cardiac surgery. My colleague, Dave Wessel, and I know Brian Siegel's heard this many times, We work in a CICU. He goes, the first letter on the door is cardiac. Always start with cardiac. We've talked about this over and over, so I'm going to go through that very quickly. Are all the holes closed? Are there other shunts? Is there obstruction? Is there any valvular regurgitation? Is the coronary flow and myocardial function adequate? Did anything happen to the conduction system? Were any thoracic structures injured, like the phrenic or the recurrent laryngeal or the thoracic duct? And then importantly, what's the hemodynamic significance of those lesions? It's one thing to say there's a residual VSD and a 20 millimeter gradient out the left pulmonary artery, but does it matter? And I do this personally, just my approach. I do this every day in my head because all of the other care depends on this assessment. I'm going to skip this. What's the clinical significance of these shunts, regurgitation? And in the short term, does the patient have low cardiac output? And if not, how much inotropic support is necessary? And in the longer term, to talk with the families and ourselves, will the patient require further surgery? Is the patient progressing as expected? So we're going to divide the last half an hour into the first night after surgery and then the next 5 days. And this first night, there's a picture of a baby with hypoplastic left heart syndrome on the left here, which will look much more like this picture here in the middle with lots of stuff compared to a baby with a bidirectional Glenn or a common arterial trunk who may need much less support. Low cardiac output syndrome has been poorly defined. It could consist of, I think we all know what it is. It's a borderline or inadequate delivery of oxygen to the tissues to meet their demand. The research has used various criteria. If you could measure it, which is hard in patients with shunts, it would be a cardiac index of less than 2. In the Milrinone study, we used arbitrarily the addition of a new medication, doubling of the current level of support by 100%, or obviously the need to go on ECMO. But at least to my understanding, there's not been a universally agreed upon definition of low cardiac output syndrome. In 1975, when Grant Parr and John Kirkland published this data, the lowest cardiac index, so adjusted for body surface area, was seen in the neonates. 25% had a cardiac index of less than 2. It's strongly correlated with mortality. When the Boston circulatory arrest study was done, 171, all neonates, all with a biventricular repair for transposition, 40% had transposition VSD. They were randomized, so half had hypothermic circulatory arrest or low flow bypass. So this is now about 15 years later than the study I just showed you. And again, we noticed that the average cardiac index fell by about 20%, but 33% had that measured cardiac index of less than 2. Now, the mortality was nothing like what we saw before, but as people have seen this data before, in addition to the cardiac index falling, part of that may be due to peripheral vasoconstriction, and I'll show you some data on why that may occur, as well as with an increase in pulmonary vascular resistance. So if your output falls, but your resistance goes up, the numbers you monitor at the bedside don't change very much, right? So the systemic blood pressure, pulmonary artery pressure were reassuringly normal in that study, as were the filling pressures. And because this was a randomized study, we came up with a somewhat arbitrary score that we used called an inotrope score to compare one group to the other. That inotropic score was never meant as a predictive variable. It was meant to compare two groups. Mike Gaze and others have done great work on that inotrope score to make it much more of a predictive variable than we did in the circulatory arrest study. We know, similarly to the fall in cardiac output, that the respiratory function also deteriorates somewhere between 6 to 12 hours after surgery. That can be mitigated a little bit with hemofiltration on bypass. So there's this predictable fall in cardiac index. There's an increase in resistance. The cause is multifactorial. You can see some of those causes here. In the milrinone study, we saw something very similar. So on the top, you see the difference in the arterial venous oxygen saturation, which increases 4 to 8 hours later. However, lactate continues to fall. And I want to point this out here. Again, showing this here that even though the cardiac index falls, lactate should also continue to fall. And I'll show you an example of why that's important in just a little bit. Similarly, the work on the top there was done by Bob Hannon, Tony Rossi, Redmond Burke. Excellent work at Miami, now Nicholas Children's Hospital down in Florida, looking at lactate production in Norwood patients. Some had a BT in the dark bars, some had a RV to PA conduit or Sano in the light bars. And a very similar thing to what we saw in the Primacorp study. The lactates start higher, as you can see comparing the Primacorp study on the bottom, but they continue to fall even though cardiac output continues to fall. And this is an important observation. If your cardiac output is normal, the half-life, if that's a word, I mean, we can make it up. I've heard somebody call it the lac time. But whatever you start out with your value, it should be about half of that value in 4 to 6 hours. And we found that in biventricular and single ventricle patients. And if the rate of lactate fall is slower than expected, or as my new colleague Yves Dudekem says, the only way he knows that his patient's doing well, there's a million other things that he looks like, but if the lactate is clearing, he knows he's doing well. And if it's not, investigate the cause. Was the diagnosis right, or was the repair challenged? Troponin goes up over the same period of time, 4 to 12 hours. That peaks between 4, as I mentioned, and it's greater in younger patients. Complement goes up, but comes back down to normal. All of these inflammatory markers, endothelium in terms of the increase in pulmonary vascular resistance. I showed that slide twice. So in the first 24 hours, which of course means in the middle of the night, patients have their lowest cardiac output, their highest systemic and pulmonary vascular resistance, their worst pulmonary function. And many units are now getting to the point where they have the same staff present at 3 in the morning as they do at 3 at night. But that's hard in many units. It's hard to keep that staffing. So we have to think about a model that if we're going to have sick post-op patients, how do we provide the care that's necessary at 3 in the morning? The other thing that I want to point out from that data is that by 24 hours, the cardiac index and all of those parameters that we just talked about should return to baseline. And I've been in many units, including the one I'm in currently, where there is a concern that if I go too fast, something bad might happen. I take a different approach. You know, if a baby gets operated on today, today's Tuesday, by Wednesday morning, the baby shouldn't need anything. And I try to wean things off and get them extubated. I turn milrinone off because it has a long half-life. I extubate the kids generally, if they don't have lung disease, right to a nasal cannula or high flow. And the reason I do it that way is that if the baby doesn't act like everything's fine, it tells me that maybe the repair is not as good as I think. And I need to re-escalate support. I am in the minority in my unit that does that, I must say. In many places, people extubate automatically to a RAM cannula or to high flow nasal cannula and wean inotropic support over 2 or 3 days. And that might be an interesting thing for our panel discussion. Things should return to baseline. So anticipate that with whatever your institutional cocktail is of inotropic support and vasodilators. If you think the patient would not be well served by fighting against the ventilator or a high oxygen consumption, the use of neuromuscular blockade, sedation, and analgesia. And in the middle of the night, minimize procedures which increase myocardial demand. Now you have to be able to keep the airway clean, but you want to be sure that suctioning is safe. And maybe we'll talk a little bit at the panel also about early extubation in these patients. I'm going to skip through the milrinone trial because it's been published. People can look at that. this again shows that of the placebo arm, only about a quarter of them developed low cardiac output syndrome. So one question is, a lot of this data that's available there about low cardiac output syndrome and lactate production and all of that is old data. Was the data the same in 2012? And I'll show you some data on that. And is it the same in 2020? Is it different in neonates? Is it different in single ventricle? Everything we do now compared to, for example, the circulatory arrest study where we measured thermodilution cardiac output is different. Perfusion is different. Philosophically, we approach the babies differently. Medications are different. Ventilation is different. In the circulatory arrest study, they were all on neuromuscular blockade and were receiving on average 20 micrograms per kilogram of fentanyl. I mean, of course they have low cardiac output. So if this is what happened in the 70s and a lot of the patients died, and then in the 80s it started to look like this. So the output, the frequency is less common. And then in the early 2000s, where are we now? We talk a lot about the postoperative slump. I'm not so sure that we should be using the same characteristics. It's not been studied in a long time. My own experience would suggest that yes, cardiac output falls, but nothing like it used to. Most patients do well. A lot of units use significantly less support to reduce time. And then how do we identify these patients that still require significant inotropic support? I think the data and the studies that we did 25, 30 years ago must be repeated now. How do we identify this patient, which is infrequent? Do we treat everybody with a lot of support to prevent that one? Are we fearful of that one out of 50? Or do we hope and think that we're doing the right? I don't know the answer to this, and it will be interesting, but the patients that move in that negative pathway are now few and far between. And Paul said this to me: how can we use our monitoring to reassure us that we can wean everything off, our NIRS monitors and all that sort of stuff? We use it a lot to say somebody's maybe not doing well, but if the monitoring is going in the right direction, maybe that should be something we investigate as a clue to wean the patient more quickly and move them through the intensive care unit. Again, these are all going to be on the slides that will be on YouTube if people want to take a look at them. I said before, good postoperative care begins in the operating room. We were talking a little bit before in that you need spectacular surgery. You need a great surgeon. It's necessary, but it's insufficient. The nurses and the bedside teams have to be as good at their job as the surgeon is at hers or his, or this stuff will not work well. And as Dr. Castaneda once said, the whole thing is only as strong as the weakest link. Again, I'm going to move to what I want to talk about because we took a little too much time here, but I'll make these available. I apologize again. I want to talk about the last 5 days. We did the audience poll here. So I'm going to talk about the dark side of pattern recognition. We know what these patterns can be, but sometimes we can be blinded by our blind spots, the lack of seeing the obvious, fitting the data to a predetermined hypothesis. I have to be honest, I see this a lot in early on in people's career, that the data is supporting what I think should happen. Other problems are not asking for help, as we say in our unit, phone a friend. That's a problem at my generation and me. I think I sort of got this all figured out. And we have lots of smart people that we work with, and asking for help is very, very important. Not asking the chief or the senior staff questions, or the chief or the senior staff not being available for those questions. These are the human factors that can undermine an otherwise good repair. This is something that we looked at stage 1 Norwoods, very similar to what we just saw. The inotropic use is center specific. So I want to just share to end, and then maybe we'll go on the panel, is pattern recognition for the next 5 days. Now, we published a series of arterial switch patients from the Boston Circular Arrest Study. We looked at all of their hemodynamics in their postoperative course. So this is in Boston 30 years ago with one set of bypass strategies, et cetera. And then we looked at a similar, slightly smaller group, but roughly 100 kids that had a stage 1 Norwood. 10 years later, different bypass strategy, different postoperative care strategy. And what we found, what I think was pretty interesting, is this is a graph of urine output over the first 24 hours. So the pink patients, the transpositions, are biventricular repairs. And the bluer or aqua patients are hypoplastic left heart syndrome. So you can see very similar patterns where on the operative day, urine output may be good, but then starts to get a little bit sluggish. Again, 20-year-old data, but very similar patterns. The fluid balance, as you might expect, input minus output, worked that way. The serum creatinine, much more acute kidney injury in babies after a Norwood operation, but they all tended to go up on the second postoperative day. Many units, like the one I'm in now and the ones I've been in, use a lot of diuretics, driving the BUN up into the 20s, 30s, and sometimes higher. White blood cell count and platelet count in particular. This is something that, this was studied in the 70s, actually. A surgeon named Hank Edmonds tagged platelets with a radioisotope. The platelets become dysfunctional as soon as they're exposed to the plastic in the bypass machine, but it takes the spleen about 2 to 3 days to remove them. So patients tend to drop their platelet counts on the second and third postoperative day after surgery, at least these two operations, as well as adult bypass grafts. I suspect that this happens to some degree in all of the patients that we put on cardiopulmonary bypass. So we've talked a little bit about planning this. It's very unit specific, but what's consistent across it is to know your patient's data, to trend your patient's data. For me, I'm a visual person. I like to see the curves. Some people like to look at tables, but however you like to look at your data, it's very helpful to trend that over time and to know what that expected pattern or that curve should look like. And if the postoperative course deviates from the expected course, investigate why. Yes, you have to simultaneously treat what's going on, but you have to understand the why. Lactate should do this, or should it? If we looked at a patient that did that, would you attribute that plateau of lactate at 4 to 6 hours normal? Is that from low cardiac output? And I want to emphasize no. That variation from the usual pattern demands assessment before you ascribe it to, oh, well, that's the patient having their slump. Lactate should clear consistently. Should look like that. So the curve, we've said this a few times now, the half-life of lactate is 6 hours, even in patients who have measured falls in cardiac output. We say this over and over again. This was taught to me 30 years ago by Dave Wessel and Peter Lang and others. If a kid is sick in the cardiac ICU, it's their heart. We've talked about the platelet count should look like this. What if you had a patient that did that? No, you've got to figure out why they have thrombocytopenia. Not necessarily on day 2 or 3, but why is it persistent on day 4 and 5? I would have concern about that patient. No there, and yes here. It should be coming up. So again, the variation from the usual pattern demands assessment before ascribing it to, well, that's what happens on bypass. So I'm going to close with 3 slides. The first is this one, and this is very unit specific. So I would encourage you to go back to your units and look at your last number of patients that have had a particular procedure and plan out their flight path. What should be your target? So for example, a patient who undergoes a repair of tetralogy of Fallot today is going to run the risk of junctional ectopic tachycardia and arrhythmias between Tuesday, peaking Wednesday night, middle of the night, into Thursday. They're at risk of low cardiac output and maybe some decreased urine output tonight, but that should get better. Their platelets and their white blood cell counts may fall in Wednesday into Thursday, and they should be more comfortable and start to diurese more. And if you leave a foramen ovale, they should start improving their oxygen saturation as they shunt less through the PFO as their right heart improves. In my center, in centers I've worked in, this would be the flight plan that I would expect. And if the patient deviates from that flight plan is when I start to say, okay, what should we be doing? I would also add to this, I didn't on here, is off ventilation and off IV inotropic support. Consider setting up something like that for your patients in the operations that you do most frequently. And then see if you can improve on that. If a baby today had a arterial switch, arrhythmias I make as a red flag up here. Single isolated stuff can be a problem, but as we've seen, patients that have unexpected ventricular arrhythmias could be their coronaries. There's about a 5% risk of seizures if the baby had a switch Tuesday into Wednesday night. We've already talked about low cardiac output here, and the same thing that we talked about with urine and irritability down here, but most switches should be extubated. Our group said 2 to 3 days when we did the poll before, and so feeding tends to increase. And then finally, if you look at patients who had a stage 1 Norwood operation, again, risks of seizures. Oh, I put this in Spanish. There we go. The days are incorrect, but low cardiac output, risk of seizures, decreased urine, increased urine, much slower oral feeding, and irritability and pain. So to summarize, the first 24 hours after bypass requires aggressive and anticipatory support, especially in the neonate and young infant. I believe that this support with a good operation can be removed rapidly and not necessarily weaned, but de-intensified. We rarely wean up things. We usually start things and wean. We don't start and stop. And as I've said multiple times, and I hope is the takeoff, it's if the postoperative course is at odds with your expectations, question the assumptions. Is the diagnosis correct, first and foremost? Was the operation correct? And is the heart rate appropriate? Talked about that before. Need to have, in addition, what Paul was talking about, trust but verify, figuring out where you are in your training, how comfortable you are with completeness and efficiency. So again, I want to thank everybody who, I'm afraid Stephanie was doing a case, so she didn't have a chance to come in. And then showing the true PowerPoint geek that I am, I spent all this time making this one slide that looked like a news discussion. So I'm going to open up the mics to the panelists. I want to thank everybody for spending some time today talking about this issue. I think, how do I stop my screen? I tell you, it's easier to put in ephemeral line. Stop share. There we go. Now I can see everybody. Thank you all for hanging around. There's a bunch of questions in the chat. Duncan, I think you're probably the most senior person besides me here on the panel. I'm sure I missed something. 2 minutes on your thoughts.
Okay, one point that I would make that I slightly disagree with you is that you say that that everything begins in the OR, and certainly you need a good operation. But actually, I would go a step before that, because if a surgeon gets the OR with the wrong diagnosis or the wrong information, the pre-op assessment by the cardiologists and others has been incorrect, then they're on the back foot from the get-go. And I think that leads to poorer surgical performance, and that was shown in the UK arterial switch study, which showed that if the surgeon knew there was complex coronary anatomy, it made no difference. But if they didn't know it and they discovered it in the operating room, then the outcomes for those babies were potentially worse. I think that's one.
Yeah, I should have emphasized.
I think the other is, yeah. I think the other is just randomly thinking about drugs. We all use different drugs. And okay, most of us use Mirena these days because that's one of the few drugs where there is at least some evidence. And actually, I think that it's but I would say that actually it's really not necessarily the specific drug that you use, but the way that you do it and your team uses it. Because there may be parts of the world that don't have milrinone, or it's very expensive or whatever. You can do 90% of what, 95%, 99% of what we do with some very basic, very cheap drugs. So I don't think, or without nitric oxide, for instance. Yes, okay, there are times when it's useful, but I think it's the person, the team that's more important than the specific drug. I think asking for help is the third thing I would say. I still ask for help because I think you need a reality check. If you're so arrogant that you don't ask for help, or at least just run something by, phone at one of my colleagues and say, "Can I just run this by you? I don't think I've missed anything, but just give me your opinion." I think that's very valuable. And I would say to fellows, I don't mind if you call me, but I do mind if you don't call me. So, there's no such thing as a stupid question from a nurse or from a fellow or someone who's sort of very junior. The important thing is they know they can ask the question. So the authority gradient is really important. They have to know they can pick up the phone and talk to you without being shouted at. And that leads to good outcomes.
Thanks, Duncan. I'll flip over to Brian since he's just started this job. I know, Brian, you would call Duncan in a heartbeat. I'm quite sure about that, even though it's international call. But things to add? We don't have to repeat anything because I want to be sensitive of everybody's time. But key points that weren't mentioned or need emphasis.
I mean, I think harkening back to the beginning of the discussion where the environment really, really matters, and kind of echoing what Duncan said about being willing to ask for help and receive that help. That's kind of been the biggest thing for transitioning to an attending, is having that support system of not being afraid to ask anyone and everyone around if this is something that we do at this institution, or if there's any other thoughts. I would also echo what Duncan was saying about the inotrope choice or the vasoactive choice. I think what I'm learning moving from different institutions is that it's more important to recognize the underlying reason why you're using a vasoactive, whether you're looking for afterload reduction from milrinone, and can you get that in a different way versus inotropy from epinephrine or milrinone. And I think it just adds a little bit of flexibility to what your postoperative care can be, and lets you manage patients a little bit more individually.
Thanks. Jai, I'm moving up my screen this way.
I don't know that I have any. I thought that was an excellent talk, Gil. What I wanted to do is maybe pull some of these concepts together in one continuum, because I think this has all been very well said. That the concept that Duncan was introducing about essentially having an expectation of exactly what that postoperative phenotype, a combination of the patient behaviors and the support strategy, is going to look like, becomes, for me at least in my practice, the mechanism of understanding when I need to move away from efficiency and focus on the details. If you have 4 or 5 post-ops coming back, and you have an observed versus expected interaction with each of those patients as they arrive in the unit, if your observed patient is very different from your expected patient, that's where you stop being efficient and you try to figure out why, because that's a patient that's clearly in a different category of risk, and that might be more, it might be less, but you need to understand which of those categories that patient falls into. And then just a comment about the outlier detection. Outlier detection is our cognitive exercise in critical care. All of our patients are at increased risk, and what we're trying to figure out is which of these outliers is an outlier in a concerning way. But we focus on outliers in concerning ways at the expense sometimes of outliers that are outliers in an exceptional way. And to have a robust science and to continue to push the envelope and rapidly de-intensify these patients like you're describing, we need to be as responsive to outliers that are far exceeding our expectations and try to understand why that is happening, so we can try to make that more the norm than an unexpected course.
Thank you, Jai. Brilliant as always. I could listen to you for about 2 hours, so I'm just, I'll ask you lots more questions.
There was actually one last thing I wanted to say about systematic practice. Some people still believe that systematic practice in postoperative care is constraining, but I think it's a really important way of organizing everybody in your unit to be effective at this outlier detection. Your most junior member of the team is able to identify deviations from what's expected, even if that deviation is just, say, for instance, an increased frequency of lab assays over what would typically occur in that patient population. And that's a way of non-verbally communicating that the patient is in a different category of risk. So I think setting up these expectations, which is what Peter, I think, was alluding to, and saying to people, this is, for instance, how frequently we're going to be doing gases. If you're suddenly doing gases 3 or 4 times as frequently as you said you were, that very junior nurse at that bedside will have a clear understanding that you're in a different position than what you expected.
And hopefully asks why, and is part of the process. Grace, how about you?
I think everything was very well said, and teamwork is key in every place, but especially on the CICU. Nothing to add.
How's the pool?
Oh, it's very cold here. It's not a pleasant weather, but this is the only cable that I could find without noise.
It looks beautiful in Portugal. And
Portugal is very beautiful, indeed. But the talk was very, very good, and focus on the team is always the most important part.
Yeah, it is the team. It's the panel. Yeah. It's the audience. That's really what makes it terrific. I bet it's just as nice in the Netherlands, Peter, as it is in Portugal, right? How are things there? I wonder if he's still there.
I think he went to get his night shift.
Ah, okay. Jill, what's your perspective on all this? What do you think that we could do as intensivists to work to get this great information spread, and how did this affect, what did you think of this?
I thought it was great. Of course, I echo everything that you said. I think the most important thing is emphasizing asking why and not settling for the trajectory, knowing what the trajectory should be and figuring out why you're not on that path instead of just remaining stagnant. I think getting this out to more people as much as possible is really helpful.
Yeah, the why is a huge, for me and the rest of the unit. It's not just, well, let's drop an NG tube down and feed the baby that way. Why isn't the baby feeding? Has to be something as mundane as that, as opposed to why do we need to have the chest open? All of those things, I think, need a why.
Yeah.
I want to close with David, and then, yeah, I'm sorry. Go ahead, John. I interrupted you.
Oh, no, that's okay. I was just going to mention, just like you were talking about getting gases more frequently, that's just as mundane, but why?
Yep. Yeah, why is the key. David, the sun has not come up in San Francisco yet. It's still dark there.
Still the same. Thanks, Phil. I think this was really great. I just brief comments on the kind of medical or content side. I was interested to see that calcium wasn't listed in a lot of the meds, especially for post-op neonates, which I really like because of the kind of cellular basis for the sarcoplasmic reticulum in neonates versus older patients. I think is a really interesting concept. So that would kind of be on the medical side.
Before you go on, I just have to tell you that our good friend John Berger, he calls it Satan's ion. So there can be varying differences of opinion. It's one of my favorite things. He has so many great things that he says, but that's one of my favorites.
I think all things in moderation, right? I think if you have it at the right level, then it can be an inotrope for neonates. I think if you've got it at higher, then it causes apoptosis, so that's an issue. On the kind of non-medical, more like team or psychology of what we do, this might even be, to your question before, one thing you could consider adding to your 9 Bs as maybe a 10th B would be tolerating failure. And I mean that in patient care, but also in your career as you're guiding trainees, being able to tolerate when you fail. And so I really like your and I ascribe to kind of the same mindset of turning things off, extubating patients, turning medications off. I'll often say that the patient either has to prove that they need to be intubated or prove that they can be extubated. But we're not just going to kind of continue to drag our feet. And so I think as long as you can do that safely, I think really proving that the patients need the therapy that they're getting. And I'll often say, you know, people will say, well, this patient's requiring milrinone. And I'll ask, are they requiring it or are they receiving it? Because at some point, that line really gets blurred. So I really like that mindset that you kind of put into the talk today.
Thanks. I have sent a number of papers I reviewed back when they say a patient required X or required Y for exactly the reason you bring up, is all we know is they received it. That's all we know. And my dear friend Sasha, who has started this whole thing with so everybody knows who's on this. This was Sasha's vision. And he energized a number of us to do this when the pandemic started in March. And we've had over 14,000 individual participants to the various webinars that have happened. And Sasha, that's real tribute to your vision. Thank you. Do you have any last words for everyone and any comments as the only surgeon on the panel? This is the best surgeon when you can't hear him talk because he's muted. They're the best kind.
Thank you very much. I think that today, as you said, the most important message is for the people that cannot reach any meeting, any congress, and was able to receive such a unique and extraordinary message from all over the world, from different point of view. I only add one thing, and I think that is my view. Please don't look too much to the numbers, look to the patients. Because sometimes I agree with all of you, and I believe that it's all things are very important. But the approach sometimes became very connected to the numbers. As you say, the lactate, the last 100 case we did, we have now the pump, fantastic pump, and lactate is 1. But then the patient can develop 100 of lactate in 1 hour. So I think that the way to look also, we have to change something because lactate is important, but we are now very tolerate lactate. So my idea is don't look too much to numbers, but look more to the patient. This is what I feel.
Thanks, Sasha. I'm going to call on David for just a second, but I did want to add one other thing that's come up a lot recently, and I'm sure everybody here will agree. What separates out the places that sort of push things forward besides the research is what do you do with what we see all the time, internally inconsistent data, right? So you have a patient that's got great cardiac output, great urine output, good heart rate and blood pressure, but the filling pressures are 13 and the lactate is 4. What do you when you have good ventilation strategy but an x-ray that looks bad, or a kid that's comfortable or an x-ray looks bad, and you have internally inconsistent data? And to me, Sasha, what you said is so key, because if we're only focused on the patient, we think that they think fluid balance is positive, but you can't feel a liver and there's no edema. All those sorts of things, we have to come back to the patient. David, I'm going to give you the last word.
Oh, wow. Last word. Well, I just wanted to share, I completely agree with that sentiment, and it brought up a really great quote that I recently came across from John Audubon, who founded the Audubon Society and is a expert on birds and wrote a whole bunch of bird books for those of you who aren't familiar with it. But he wrote that when there's discrepancy between people looking at birds and looking at his books, and he wrote, when the bird and the book disagree, believe the bird.
I like that very, very much. That's a very good way to end this. And my friends who agreed to participate on this on short notice and no planning, I couldn't thank you enough. It was terrific. We'll share the evaluation with everybody. And if people have ideas on other topics or whatnot, please put them in there. And I'll turn this over to Grace to close us out like we usually do.
Hey, everybody, thank you very much. Thank you to the panel. And Gil, this series has been amazing, and we really thank you for that. Thanks everybody for watching that and to participate. We hope all of you can join us on the activities next week. And this week as well, on Thursday, we are going to have the nightmare case. That is going to be awesome. Please join us. And you're going to receive on email a SurveyMonkey a survey. So you're going to be able to tell us what went well and what went not that well, so we can make this webinars better for all of you. Thank you, guys.